Hi, welcome to another episode of the ARC podcast with Jen and Lindsay. Jen, how are you today?
Lindsay, we're not going to ask each other how we're doing today because we're not.
Well, it's just an easy intro. I'm not asking you to tell your week story. Like, we
I'm
don't
just
have
kidding.
time for our story.
We just both were texting each other this morning about, I mean, my kids went to school, so it was like a miracle. You have one home. Husband's driving us crazy, just the regular thing. So I was like,
Mhm.
maybe we just shouldn't
Yeah.
even, we'll just jump right in, just jump right into the pod today.
But I feel like people want to know how we are in the beginning for 20 seconds. We don't have to get
You're
into
right.
it.
Well,
So
I'm actually all right. How you doing?
I'm hanging in there. The easy kid is home today. So
There you go.
we're Who would have ever thought that autism would be easier than a 6-year-old girl?
I have the
So
same thing going on over here. My 11-year-old is honestly more of a handful most mornings. So anyway, let's get started. So we are excited today. We have a really great guest, someone that I know really well because I got to actually do the Lend program at Cincinnati Children's with her as my supervisor, and I was like so pumped to do that. And obviously, I know her just because of my son has autism, and we do a lot at Cincinnati Children's. So we have Dr. Steph Weber. Steph is a clinical psychologist at Cincinnati Children's Hospital. She is the Next Step Clinic Director and Next Step Collaborative Chairperson, Act Early Ambassador to Ohio, which is pretty cool. We want to learn more. And this is all at the Division of Developmental and Behavioral Pediatrics at Cincinnati Children's Hospital Medical Center. So, welcome, Dr. Weber.
Good morning. Thank you for having me.
Yeah,
Excited to be here.
we're excited because today we're going to be talking all about your Next Step Clinic and some of the things you're doing here in Cincinnati for children who have been exposed to opioids, substance abuse. We decided this was an important topic when we had you on come on and talk to our parent mentors because a lot of
mhm,
our teachers and parent mentors are seeing some things at school that they're like, "Whoa, what's going on with some of these behaviors and younger children?" And then we have the COVID in there too that's kind of like screwing up
Oh,
some things.
yes.
So we thought, let's learn a little bit about your work. It's really kind of groundbreaking, exciting stuff.
mhm.
And you sent me like a PowerPoint when we did our parent mentor group, and that PowerPoint is just amazing. I learned so much. You think you know about this stuff from like reading and listening to podcasts and things, and then you learn from the source. And one of the things I read was, according to the CDC, 1 in 3 women of reproductive age filled an opioid prescription each year between 2008 and 2012. So I just thought,
Mhm.
That's
what a
insane.
number. And
Yeah.
this is
Mhm,
Yeah. And it's
this
it's
is
a very um misunderstood phenomenon. I think so many people, like with any cycle of addiction, there's so much stigma, and they make assumptions that it's on the individual and their choices and their behavioral um, decision making powers are limited and lacking, and therefore that's what got them down the path to addiction. And so often that's not the case. And these women that you just read, these numbers and these statistics, these are real life people who go to their doctors asking for help. And those doctors wrote prescriptions for them to fill. They didn't fill their own, they didn't write their own prescriptions to fill.
mhm.
So they were following healthcare orders. And then these drugs are so strong that they have the potential to make chemical changes to the brain, and especially when we're talking some of the higher powered illicit substances like fentanyl, and some of the ways in which that they're cut on the street and sold on the street, that could lead to um, the craving and kind of the addiction characteristics even with one or two uses.
yeah.
So it's a really misunderstood phenomenon. And again, I my heart breaks for folks that you learn about where they were in a car accident, they were prescribed these medications, they took these medications, and they really weren't followed with the best healthcare. and it led down this path that was really unfortunate consequences that then they were stigmatized because of.
Yeah.
Mhm.
I mean, the stigma is real, and when you really think about, how much you yourself have these kind of like preconceived notions, and uh I think it's something that we all, you know, have. And parenting itself is like a judge. We know we're all so judged on like how we parent. And then I think like us autism moms, like Lindsay and I,
Mhm.
feel that too. And then so I think this is so like connected, not only with what you're seeing in children and their behavior, but with like our DD population and the parenting. I think this is all kind of like very helpful to learn this, even if you don't have this particular issue in your life, which obviously you do. You just probably just don't know about it.
Correct.
I think
Yes.
everybody knows someone
Yes.
with addiction.
Especially in this area, the greater Ohio, Columbus, the I-70 corridor is such
Mhm.
a hotbed of all of the opioid crisis, and it's changed and morphed, but it's definitely not gone away. And so we're seeing different types of demographics that are users at this point, but we're not seeing any decreases in
Mhm.
the volumes. And really, more often, we're just seeing more powerful substances that are out and about.
Yeah, it's scary.
It's very scary.
What are the unique characteristics seen in children who've been exposed to opioids prenatally?
That's a great question. And I get this question a lot. And I always have to give the caveat that research in any population of human beings is very tricky when we think about substances prenatally, substances in utero, because we can't have a control group that says, yes, we are going to give you no substances, and another group that says, yes, we are going to allow this baby, this fetus to be exposed to fentanyl or heroin or methadone. So research is not clean in comparison to other research studies. And so we can't ever at this point say this is a result of the opioid exposure.
Mhm.
In many studies, we also do see that on self-report, children that were exposed to opioids were exposed to multiple other types of substances, like
Mhm.
methamphetamines or amphetamines, and as well as tobacco use. And I think that's also a misunderstood substance, that just because cigarettes are legal
Mhm.
in our state doesn't mean that they're not a substance and a chemical that can be harmful to a developing brain. And so more often than not, we see polysubstance use, polysubstance exposure. And so it's really hard to tease apart, yes, this is because of the opioid exposure. So we
Mhm.
can't say that. However, what we do know from what we're seeing in our clinic with children with prenatal opioid exposure in the 3 to 5 year old age range, so that preschool time, is we are seeing some pretty interesting characteristics around sensory behaviors and
Mhm.
around challenging disruptive behaviors. Those are two of the kind of presenting concerns that we're most often seeing. Families saying, I'm worried about my child's problem behavior, and I'm worried about their sensory seeking or sensory avoidance. And as you know, as the world of autism, sensory and behavior is a lot. Um,
Mhm.
and so that could impact the way that you eat, the way that you get along in a preschool, the way that you take a bath in the evening. So, a lot of these sensory and challenging behavior concerns are really impacting quality of life for families and for those all around the child.
So is this like autism? Can we just treat it like autism?
So we don't have a name for it. That's the tricky part. Neonatal abstinence syndrome and neonatal opioid withdrawal syndrome, so NAS or NOWS, are the two names that we use when the infants are infants, when they're within the first year of life. And that is how, in the state of Ohio, they can get an automatic qualification for early intervention, is
Mhm.
with those designations. So That's wonderful. We are one of the handful of states around the country that knows, hey, if we get ahead of this, we can really make a nice difference with early intervention. However, after the 1 year old um, time period, we don't have a great name. So, what we're oftentimes diagnosing based on our clinical manual that we use to make healthcare diagnoses, the DSM. So, we're using diagnoses like attention deficit hyperactivity disorder combined type predominantly. And we've seen about half of our kids that have come through our preschool age clinic actually meet full criteria for ADHD combined. That is predominantly what families are saying. It's the impulsivity, the hyperactivity that are causing the most family disruption.
Yeah.
There's also a smattering of other diagnoses, speech related, um, cognitive delays, those types of things that we're seeing too. But it's by and large the sensory dysfunction and the ADHD type symptoms. But it's not a true ADHD. That's what I always say to families. It's not that neurodevelopmental ADHD that we see typically without exposure. It doesn't respond as well necessarily to all of the stimulant medication. And we still have a long way of research to go to determine what kinds of medications could work. It's not the same type of characteristics. And so the treatments like we have for autism or ADHD, we still don't know yet. We still have to work on some really robust research treatment studies to determine what are going to be the best outcomes and the best interventions for these kids.
Yeah, I would think the
Mhm.
medicines for ADHD and like some of the medicines maybe our kids use who have autism would be tough for a child who's been exposed because
Mhm.
their body was were already exposed to like some stimulants, medicines, and things like that. Is that why they're not really helpful, or just because those were designed
Well,
for ADHD and this isn't
It
exactly
you know,
ADHD?
I can't speak to the mechanisms of all of that, but I will say that that is also kind of getting at a little bit of another um uh myth, I guess, for lack of a better word. It's a myth that just because a child was exposed means that they shouldn't be prescribed medication to help them. And what we find is actually one of the things that makes the most sense to me is that if you have a youngster and that, preteen, teen is struggling,
Yeah.
what is a common thing that folks do to cope? They resort to self-medication. And so if
Mhm.
we don't let the child get to that point where, they're in their teenage years and they are struggling because we have good interventions and we have good medication regimens, then we're not necessarily setting them up to self-medicate. And so that's what we
Mhm.
do see in research, that kids actually do better if they are on a controlled medication, overseen by their doctor, in agreement with their family, because they're not struggling as much as they would be without it.
Yeah. But does that get to like some of the that's an interesting thing because I had no idea. That's a
Mhm.
really good point. But does it get to like since the mom um is an addict or hasn't was prescribed these medications during pregnancy, then would she maybe have an issue like giving her child like medications, like controlled substances again and be like,
Yes.
"Oh, yeah."
I will say that I've heard that a lot in our families. So we talk with individuals with substance use disorders, and they oftentimes say, yeah, I have a hard time thinking about getting a prescription for my 4 year old. I think anybody would, though. I think
Yeah.
that's just, good critical thinking as a parent, weighing the positives, weighing the negatives.
Mhm.
And we also see it in grandparents. I see that a lot in the grandparents that are raising grandchildren, for that major fear of what that could turn into. Um, and then a little bit more in the adoption and the foster care community, but foster care has a lot less control over, for better or for worse. The foster parents kind of have to do what is recommended,
Mhm.
and um, and the adoptive parents definitely have more hesitance as well. But so I just think things like this to help educate folks to say, the kid is struggling. Let's not let's not keep them struggling because then they're going to turn to alternative, potentially unhealthy coping, especially kids that are already facing that ADHD profile, which comes with social and emotional delays for their age.
So what else besides medication? Like what other evidence-based treatments help these kids?
That's a great question. And we don't have a lot of really solid studies that say, yes, this is an intervention that works for these kids. The ones that we do, I will say that I have pulled a lot from what we use with kids with other neurodevelopmental disabilities like autism, Down syndrome, intellectual disability. And it's things like using visual supports. Well, if
Mm,
you can use visual supports, doesn't that help all kids? Yes, it does. So why not try that with this population? And it turns out this population, we're also seeing some anxiety and probably, I haven't looked at our numbers yet in our clinic, but anecdotally, they're higher than the general population of kids their age. And so when we are using things like predictive routines and warmth in our responses and more of a teaching opportunity and in place of a lecture or a correction, then we're having better outcomes because we're also being mindful of that anxiety.
yeah.
And so that's where the visual schedules, we all know, like, who can live a day in their life without their schedule on their phone or on their computer? No one. But we expect kids to walk around, all kids to walk around all
Mhm.
day long, just knowing it in their heads. And that's oftentimes not fair, in my
Mhm.
opinion, to our young ones. And so giving visual schedules, making those types of visual supports available, I've found in my clinical treatment practice have been helpful, as well as in what families have reported when they come back and say, "Oh yeah, this really did seem to help us stay on track."
Yeah. So in your next step clinic, I saw that you have like you work really closely with an occupational therapist.
Correct.
And
Yes.
OTs are our jam. I think Lindsay and I would agree
Oh
that
yes.
like OTs are my
Yes.
favorite people.
We're on an
Mm.
OT break right now, and I miss our OT. Like,
OT
we
Oh
break.
yes.
need
Yeah.
and, where we are, because the wait list is so long, you do 6 months of your clinical, like, therapy, and you get put back on the wait list, and whenever they have a
Wow.
time, they plug you in. Normally, it's like a 4 to 6 week wait, but I mean, the turnover for OTs and speech and all of that is huge, so we're in a big turnover right now. Like, Whitman hasn't had speech since October, and he won't start up until the middle of March.
Oh goodness.
And we haven't heard he hasn't had OT since October, and we haven't heard when they're gonna be able to squeeze us in. But it
Yes. OT
from
though. Ooh, yeah.
yes, OT is our lifesaver, just with life skills in general. Like,
Yes.
that is the bread and butter. When my Mimi broke her hip, that was the first thing that I asked. I was like, "When did she start OT?" And they're like, "Well, we gotta
Yes.
do physical therapy." And I was like, "No, she needs OT. Like, she needs to be able to figure
Yeah.
out this new life
Yeah.
and
Yep.
house and everything. Like, you need OT. Like, OT is the top thing."
Yep.
And like a big one is how like occupational therapists can help parents learn some of like
Yes.
that
Absolutely.
co-regulation
Mhm.
and like how important that is. So can you talk a little bit about that? Because I think with Jack, it was like a huge aha moment for me when I kind of learned that how important I was to and my
Yes.
husband was to our
Mhm.
relationship and pulling him like forward and making progress because if I'm not regulated, it's really hard to get him regulated.
Oh
Mhm.
And so
gosh.
we all
Yes.
have to like and especially with a parent who may have struggled with addiction, I would think would really need a lot of this education.
Well, and I have a grid that I sometimes share, and it's this idea of co-regulation is key. And co-regulation is simply um it's simple in thought, but it's so
Mhm.
complex in practice. And it's the idea that you just hold space for the child's emotions, but you have to have somebody that has held space for you, and you have to have that idea of being emotionally stable. and emotionally competent and
Mhm.
emotionally aware, really, of, okay, what do I need to do with my body and my reaction in this moment to make sure that I don't make it bigger for my child, and to make sure that I'm providing that stable, comforting experience. And I think that
Mhm.
that's what's so challenging for all parents, because you're in the grocery store and your kid just seems, just trips and falls and he's screaming, 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 and you have people looking at you. So then you're dealing with that emotion inside while trying to get
Mhm.
them to hush and not have people look at you, right? But what does that child really need in that moment is just you to be there, silence, comforting, right? Holding, loving on them. And that can be really, really hard when that happens so many times throughout a child's day.
Yeah.
And that's the trick, I think, with the co-regulation is that it takes thousands of interactions in a young child's life, if not more than thousands, to really get to that healthy place. And and it's okay if families make a mistake too. And that's what I think so often we recognize, um, and talk about this in treatment. We don't have to be perfect.
Right.
We just have to work hard to try to fix that the next time and do it better the next
Mhm.
time.
Yeah.
But co-regulation with these kids is incredibly important. And again, that's where the OT and the behavior
Mhm.
therapy can help. So kind of when we think about what we do know from evidence, we do know that there's some research in regards to, um, parent-child interaction therapy. And really, what I find is that there's this phase one of parent-child interaction therapy, or PCIT, that's called child-directed intervention. And the idea behind that is exactly what we were just saying with co-regulation. The idea of, I'm just going to comment on what you're doing. I always call it being a sportscaster because I'm a big sports nerd. So
Mhm.
just how do you be a sportscaster of your child's play, of your child's daily life? Oh, you put the blue block on the green block, right? Because
Mm.
it's just a really nice way of teaching families how to play again, teaching adults how to play because we kind of forget.
Yes.
Mhm.
And play is not, what color is it? What sound does a cow make? Yeah, where
Mhm.
does
Right.
this one go? Right? It's not a test, it's play. And
Yes.
so I always talk about that in treatment too, around, how do you just narrate your child's play? And that is incredibly validating, following along with their play. I
Yeah.
think for PCIT, where I get held up and where I learn a lot from the other families of children with, exposures or who have been adopted or have come from hard places, is that phase two of PCIT oftentimes includes a timeout procedure.
Mhm.
And whenever you talk about that with any type of family, that is not biological, and even many biological families will say, "Ooh," and they'll
Yeah.
cringe at a timeout procedure. And really, that's where I think we have a long way to go in the research, is to figure out how do we navigate that aspect of, like, when a behavior is troublesome or unsafe, how do we, in a systematic way, teach families how to approach it? The best that I've learned and what I use in my own home is doing redos. And that is out of Texas Christian University and the Karen Purvis
Mhm.
Institute. They've done a lot of research with families of children who have come from, um, orphanages throughout the world, who have come from really hard places. They haven't done specific research on children with prenatal substance exposures, but they have with children with other types of trauma backgrounds. And
Yeah.
so I really like that approach, and we use that a lot. Okay,
Mhm.
you hit me, and I might not say that out loud, but I'll say, "Okay, Easton, it's time for a redo. How would we do it differently the next time and show respect?" And my
Mhm.
son's 3, and he does redos, and he knows what to expect from that. So
Yeah. I think that's great because 'cause I'm the person that
Mhm.
cringed at the timeout stuff too, and I don't know, and I think a lot of teachers feel like, we're stuck here because this
Mhm.
behavior is not acceptable, and, like, there's other kids in the
yeah,
classroom, and we really don't want somebody getting hurt, and we don't want this behavior to continue and, like, you
correct.
know? And so I think that redo is, like, really important. And you talked about, like, it's the you're the psychologist trying to teach the parent and trying to like the whole family unit, how
Yeah.
to work through all of these big issues. And then you have the OT helping with like the sensory and like some of that executive functioning.
Mhm.
And then you have like that trauma informed care that you both are using
Correct.
in
Mhm.
conjunction, which I think is so huge for our kids with autism too.
Absolutely.
Um,
Every person, really. I mean, when
yes,
we think
really.
about what we've just lived through since 2020, we all have a sense of traumatic reactions to our world.
Yes.
And I know some of the data that we have in Ohio is our kids are more likely than the national average to have 2 or more ACEs or adverse childhood experiences. And I
Mhm.
know in Cincinnati, 1/3 of kids have 2 or more ACEs. So 1 in 3 children has at least 2 ACEs. So there's trauma everywhere. And so if we don't look at that through like that universal lens, then we're really missing the mark for a lot of families.
Yeah.
But
And
yeah, I just had to
yeah,
throw that little data point in there for
for
fun.
sure, because it's hard when you're seeing a child like and it's almost like they go 0 to 100, like, real
Yeah,
fast, and I saw in some of your research that that's kind of what you see with kids who've
yeah,
been exposed, but it's also what we see with autism too sometimes
yeah,
and ADHD,
yep,
and
Mhm.
so it's like, how do like, it's hard to, like, not react to that,
yes,
but I think, like, what you're saying is, like, kind of, like, front loading a lot of the sensory stuff that we know, and
mhm,
another thing you talk about is the interoception piece of like the
yeah,
OT, which can you talk
Mhm.
a little bit about that? Because
Yeah,
Dr.
do it.
We're gonna have Kelly
yeah.
Muller on the podcast
Oh,
Mhm.
soon.
wonderful.
We're
Well,
excited.
Yeah.
she's the expert, but I love that work and the idea of we don't spend enough time teaching deliberately what goes on in our internal sensations, but we need to for a lot of individuals.
Yeah,
And especially these kids with prenatal exposures, they don't necessarily realize that, oh my gosh, my belly hurts and it's because I'm hungry, or I really just have to go poop.
yeah.
And
Mhm.
that, then, when you think about it, I remember it was so vivid for me one day. So, my son, a backstory, my son is adopted and he came to us
Aw.
through the middle of the pandemic. He was born October 2020, and he came to us by way of a relationship with a birth mom who was also in substance use disorder treatment, and so she took methadone daily. So he was exposed to the lower dose of opioids, and she was open and she was wonderful and did disclose that she had a relapse during her pregnancy, and so we knew what we were getting into. And I was doing this work related to children with prenatal exposures, um, it probably started in like 2018. And so I knew a lot then when he came into our lives and we made this decision. And now I've learned even more because I live it, as you all know. um, and so it has been really interesting. But the interoception piece for me hits home when there was one day we had another little kiddo here getting babysat with my son, and he just walked past the kid and clotheslined him. And I was like, what would have provoked that? And immediately realized, oh, he has to go to the bathroom. And like he was just all out of sorts. He couldn't control himself. And I just think about how we all are
Mhm.
when we have to go to the bathroom, when we're hungry, when we're thirsty. You don't want to sit and have a important conversation with somebody when all you can think about is food.
Yeah,
And so that's the interoception kind of deal for me of how do we just make sure these kids' basic needs are met? Because we can't expect them to do higher level activities and work tasks at school, or just live their daily lives if their basic needs, hunger, thirst, bathrooming, sleep, are not met.
yeah, yeah.
And so
I
sometimes
know.
those are the interventions right there.
We've done interoception work with Jack for a few years, and when it was first introduced to me, I was like, how the heck am I gonna do it? Was kinda like
Yeah,
when, like, the feeding stuff with OT was taught to me, was
yeah,
like, "We're gonna"
Mhm.
how do you teach someone how to chew their food correctly? But then
right.
once you really
Right.
dive into it and you work through it, like, week after week, I can't tell you how important it's been. Jack can tell me when he's nervous, he can tell me when he's excited, he can tell me when he's feeling like just like little changes and like we used to just happy, sad, mad, and now we have like
Mhm.
all
Mhm.
these little nice terms that he uses because he's so connected with his body, or at least he can reconnect with his body because he has the
Correct, yes.
tools to do
Yeah,
that. And
love
so,
that. I love that
if
idea of, like, reconnecting, like, doing check-ins with your own body. Yes.
yes,
Mhm.
that's exactly what it is. Well, okay, so how can we use your like clinic? Tell us a little bit about like what the clinic is and if anybody's interested in it, how they get in touch with
Yeah.
you.
That's awesome. I'd love to talk about our clinic. It is my favorite part of my month. We run 2 clinics per month, so we're seeing 8 patients right now per month. Our clinic is comprised of a developmental behavioral pediatrician, an occupational therapist, speech therapist, and child psychologist. And so the family gets all 4 of those disciplines in one visit. The visits
Oh,
are for children ages 3, 4, and 5. So we're currently like built and set up really nicely for children who had just had their 3rd birthday all the way up until just before their 6th birthday. And really trying to get a picture of those preschool age years. What we find is that throughout our state, we have some wonderful follow-up programs. Typically, they're affiliated with the birthing hospitals or the children's hospitals and within the neonatology departments. So they're going to
Mhm.
follow those kids at least for that first year, more likely that first 2 years. But what we were hearing was that families were noticing concerns with these children with prenatal opioid exposure in like 2 to 4-year-olds, and
Mhm.
then they were like, "Well, I was discharged. They told me my kid would be fine." And that's maybe the case. We don't have good research to say this will lead to quote unquote being fine, and this will lead to challenges. And so what we decided to do was to create this clinic for preschoolers to be able to be that next step, which is why we called it the Next Step Clinic. So we have our first step is that following them for their early feeding, their early brain development, early attachment, and then we're going to see them and take a nice snapshot of where they're developing from a cognitive perspective, an adaptive perspective, doing that full psychological evaluation. Then we're going to have that OT sensory piece and fine motor, and of course, we know that speech development makes the most gains between the ages of 2 and 3. And so then we got our speech therapist in there doing her evaluation, and then the developmental behavioral pediatrician kind of wrapping everything up from that big global medical picture. And so families come to us for a one-time visit, and then we hope to see them yearly after that, if not every, year and a half, so that we can follow their child's development and make sure that we're linking them and making the referrals to behavior types of interventions, occupational therapy, speech. Oftentimes, these kiddos have some very subtle
Mhm.
nuance challenges, like eye issues that
mm,
we catch because we do one of those vision spot screeners that you might see at some appointments, and we're able to catch an astigmatism that nobody would have caught before. So we get to send them to ophthalmology and make sure that their eyes are checking out because we know that could have a major impact on reading
Mhm.
and functioning in a school classroom. So it's just really a fun opportunity to be able to dig in and see things that might not be caught on screen or on screening tools.
yeah. I love that because you're exactly right. Like, it's just the worst when you have a child who's like struggling, but they're acting out in these behavioral ways and which are like maddening for like a lot of us adults around them. And then you
Yeah.
come to find out that they have this visual issue or they have a hearing issue
Yep.
or, constant ear infections or something like that. And it could have just been like
Absolutely.
resolved by getting into getting into an ENT or ophthalmology and
Yeah. Just mapping on that correct specialty care to get them their needs.
yeah.
To get their needs
Mhm.
met is really what we're there for. And then our goal is to follow them, like I said, the next year and the next year. And really the ultimate goal is to get them kindergarten ready.
Yeah.
And make
Mhm.
sure that families not only feel comfortable with them entering whatever school they're going to go to, but there's also so much stigma. And many times these kids enter school and no one has ever mentioned this child's prenatal history because of fear of judgment and labeling and not and really more this idea that the schools could use it in a negative, harmful way as opposed to using it in a way that would help the child. But I think that hopefully we can make a move on the stigma problem so that families feel more comfortable sharing. Yes, my child was prenatally exposed. These are the things we struggled with. These are what we're doing to work on it. This is how you can help. Um, and hopefully we see more kids getting served under IEPs or 504 plans or with
Yes.
supports than just saying, this is a bad kid, this is a problem child,
Yes.
Mhm.
which is oftentimes what we see now.
Yeah. I love how we started the conversation with the stigma and then we're
Mhm.
ending it with it because I think you talk so beautifully about it. And I've learned so much from
Yeah.
you on this topic since I did Lend with you. That's where I kind of began this
Yeah.
journey. And then you kind of pointed us to some resources and books and things that kind of relate to opioid epidemic. And I just think breaking down those stigmas is huge. I'm hoping that like since there's so much out there now, like in the
Yeah.
arts, movies and documentaries and
Yeah.
books about this, that people will break that down. But you're right, like we should just come at this with so much more compassion because that's the way
Mhm.
forward. Um,
Yes.
Absolutely.
and so thank you for the work you're doing.
Yeah, no, I
So
feel like it goes hand in hand with the neurodiversity movement and this idea of like, how do we fix the society and the culture while also building skills in the people that need the skills? And in this case, it's society needs the skills to understand. It
yes,
needs the knowledge to know that nobody wakes up and says, I want to be sucked into my addiction today. I want to be
Mhm.
a substance user. Nobody says that when they get asked a child, what do you want to be when you grow up, right? This isn't a choice.
yes,
And I think that that's oftentimes gets caught up in our adult brain of punishment and negativity and negative consequences, and that's where we go first. And again, just like the redos that we offer our kids, doesn't have to
Mhm.
be a negative consequence to change behavior.
No.
Um, positives, positive reinforcement changes behavior, right?
yeah,
So
Mhm.
yeah. Redos, guys. Take
redos,
that.
redos.
Yeah,
They're
I
gonna take
love a good
everything we give
redo.
Yeah, love a good redo.
Me too. Thank you, Dr. Weber. I really
Oh,
appreciate your
thank you for
time.
having me.
This has
Yep.
been wonderful, and I
Yeah,
hope
and if anybody listening does want to reach out to us, they can email us at nextstep@cchmc.org, nextstep @cchmc.org, or get in touch with one of you and get in touch with me.
there you
Yep.
go. Thank
Awesome.
you.
Thank you.
Thank you. Have a great week.